All right, well, welcome everyone to our keynote presentation at Global Health Education Day. I hope that you've enjoyed the posters, and I know quite a few people were in the workshop. For those of you who don't know me, I'm Ashti Doobay-Persaud, and I am the co-director of the Center for Global Health Education at the Havey Institute for Global Health. My co-director, Bill Leonard, is sitting there in the front, and the two of us would like to welcome you to the day. And we're really excited to celebrate our learners, all their achievements, to learn from one another, learn from our distinguished speakers, and keep building our community of educators. So this day takes a lot of planning, takes a lot of work, and I want to thank our administrative team, which was a lot of people under the leadership of Sana Caldillo, who put all of this together. So that's the Center for Global Health Education is actually a big team. You've met quite a few of our faculty who are doing judging, who are giving workshops, who've been mentoring our students for a long time. So we're very, very pleased to be able to be big part of this group. Dr. Galvin, Dr. Neubauer, Dr. Drain, Dr. Van Genderen, all of you have been instrumental in making all of this work. So thank you. And a little bit about the Center for Global Health Education, if you don't know a little bit about us. Our purpose is to inspire future leaders toward mindful global engagement, grounded in equity, humility, and social justice. And most of what we do at the Center for Global Health Education is teach ethical practice. Most of what I do is teach about ethics. I think most of our students definitely say they hear a whole lot about ethics in their feedback forums. But my first foundational understanding of global health ethics for students comes from an article written by Drs. Andrew Pinto and Ross Upshur. And so I have invited those experts here today to teach you all about this. So short bios. Dr. Andrew Pinto is the founder and director of the Upstream Lab, which is a research team focused on tackling social determinants, population health management, and using data to enable proactive care. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He's a public health and preventive medicine specialist and a family medicine physician at St. Michael's Hospital in downtown Toronto. He's also an associate professor at the University of Toronto and the associate director for clinical research at the University of Toronto practice-based research network called Utopia, and the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. Ross Upshur is currently the Dalla Lana Chair in Clinical Public Health and the head of the Division of Clinical Public Health at the Dalla Lana School of Public Health. He's also the senior scientist in the Lunenfeld Tanenbaum Research Institute at Sinai Health. At University of Toronto, he's a professor in the Dalla Lana School of Public Health and the Department of Family and Community Medicine, affiliate member of the Institute for the History and Philosophy of Science and Technology, and a member of the Joint Center for Bioethics. He's a staff physician at Hennig Bridgepoint Hospital, Sinai Health, and during COVID-19, he has served as the co-chair of the WHO COVID-19 Ethics and Governance Working Group. He's a member of the MSF, Médecins Sans Frontières Ethics Review Board, and he's an elected fellow of the Hastings Center and the Canadian Academy of Health Sciences. So we welcome you and your expertise. Thank you.
We've helped with that. I'll just start by just beginning with acknowledging, and it's actually hopefully a figure that you'll be familiar with here from Northwestern, but that here where we're meeting in Chicago is the traditional land of the Ojibwe, the Potawatomi, and the Odawa. And of course, as I was reading, Chicago is home to many Indigenous people from across this land, over 100,000 members as well. Where Ross and I are located in Toronto is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit. And Toronto is still home to many First Nation, Inuit, Métis individuals. And whenever I give a land acknowledgement, I also want to try to provide something tangible. And I wanted to just put in a plug for this fantastic textbook. If you haven't read it or come across it, highly recommend it. It's about decolonizing methodologies. Very, very short but powerful kind of book that's really influenced my work and thinking, and a really valuable resource. So this, whenever Ross and I speak, we just start with disclosures. This looks like a whole list of, things, but it's highlighted that I'm very fortunate not to receive any funding from for-profit or commercial entities. All of my research, just for transparency, is funded by entities like CIHR, which is like your NIH equivalent. And similarly for Ross, really, really limited, if any, interactions with commercial entities. So we're going to just briefly talk a little bit about ourselves, go through a bit of a personal exercise, and then go through some ideas about global health ethics. What is it useful for? Why are we here? Why has this been, something that we think will be helpful to all of your work? And how it infiltrates kind of our thinkings about teaching and learning, but also areas like research and practice, and end on kind of a new update to the framework that we presented. So as was mentioned in our bios, and we won't belabor this, we wear a number of different hats collectively between us. And one of them for me is directing this research team called the Upstream Lab, where a lot of our work is trying to put into place upstream interventions. And Ross, as was mentioned, has held many positions, including with the World Health Organization during COVID. So just to start with kind of a personal exercise, something to think about is how do you understand the world to work? And I often ask when I talk with students, if you had to explain to an alien civilization that came to Earth how the world functions, how would you explain it? What would be the language that you actually use? What are related? What are your values? What are the values that you bring into your work and your interactions with others? And then what do the answers to those first two really mean for how you should act, and also collectively, how should we act? And that's kind of a theme that maybe we'll come back to, is that none of this is about you as an individual alone. It's that, but it's also our collective activities, including our institutions that we're part of, the centers, the groups that we lead, but also our communities as well. Today in the morning, we were talking a bit about when students or trainees or faculty go into another country, they're bringing with them the history of the interactions between countries, between societies that have happened, and how does that play out into the actual work, and how should you consider that? We, of course, live in a deeply unequal world. This is just one of many maps that show the vast differences in things like neonatal deaths and where they happen. Obviously, way overrepresentation of South Asia, Sub-Saharan Africa. We see this in things like life expectancy, where we have some countries which have a life expectancy at birth of in the mid-50s all the way up to 90. So huge, almost a double of the difference in life expectancy within our world today. We see this in things like, who's being impacted by climate change. So this is historic changes in temperature and where it's having an impact. And you can see a close connection with the map about life expectancy. And this is where it's going. It's projected to get much worse. And this is going to lead to an even more unequal world. We also saw this with COVID, of course. This is deaths related to COVID on a per capita level, so adjusting for population size. Then you can see, great significant differences. To kind of put this more in an easier to understand way, it ranks the top 20 countries in terms of per capita impact of COVID. Of course, there are issues with the data and reporting and what was attributed, but you see these big, changes. And we see our two countries here, which are side by side, but are, very significant differences between the US and Canada in terms of COVID deaths. Now, This is partly related to things like COVID vaccine uptake, and hopefully as we talk about this, we all reflect on this enormous public health crisis that just was recently declared as no longer a public health emergency by the WHO, but of course it's still something that's circulating and affecting many people. But the vaccine inequity was just such a stark example of why the work in global health is needed, why we do not have a world that can tackle this type of public health crisis and emerge and actually where everybody is equal. Huge disparities. And I'm ashamed to say as a Canadian that Canada was one of the high-income countries that actually took from the vaccine distribution. Whereas we should have been in a position to be much more generous, we were one of the countries that actually said, well, we're going to dip into that stockpile. So the social determinants of COVID were something that, was very apparent. We did this rapid review looking at the literature in the first 3 or 4 months of the pandemic. And no surprise to anybody, we saw right away many results and many studies coming back that showed race, income, and occupation were key determinants of who was getting COVID and who was dying from it. And of course, here in Chicago, you see this actually one of the first cities in the US that was really pointing to the huge disparities that were being seen. This is a report from April of 2020, that said, well, we may be in this together. Communities of color are going to bear a disproportionate burden. Only 30% of Chicago's population is Black, but 72% of the deaths were amongst Black Chicagoans. And of course, this continued as well. In Canada, we have less of a history of collecting data on race and other social determinants, but with a lot of pressure from racialized communities, public health was actually forced to start collecting this data with every case of COVID that came in. And again, not surprising, showed even in a country like Canada that has a universal healthcare system, and was doing things like COVID tests free of charge, COVID vaccines free of charge, we saw very deep inequities, which may be surprising, to some, but the Black population, South Asian, Southeast Asian, all way overrepresented in terms of who was actually getting COVID. Thankfully, things got better because this data actually created a foundation to push the city of Toronto, in this case, and many other jurisdictions, to invest in community engagement and push out efforts, and really that's where we should be putting the resources. And we've actually seen these inequities decrease, which is kind of the good news story. And what's driving this inequity? So it relates to upstream factors. This is a graph of the difference between housing prices and how they've changed and median incomes, just enormous kind of outstripping of the cost of housing. The cost of housing overall in Canada is actually worse than in the US. It's and significantly worse in places like Toronto, but it's actually overall, even in smaller communities, much more expensive. We see this in many other ways. This is a really well-designed study looking at hypoglycemia and attending the emergency department for people living with diabetes in California in this case, and showing that at the end of the month, people are running out of money, can't pay for food, and are basically going into hypoglycemic states, ending up in the emergency department as well. We see this in things like how we mandate poverty for people who are living on disability. And this is not just in Canada, this is around the world. So these are, starting to be some of the upstream factors that are leading to this unequal world that we're seeing. And we sometimes see this as an anecdote, but something that's become a worrisome trend in Canada, where medical assistance in death has actually been authorized, and actually over just the last few years has really increased. What we're seeing is more and more people like this woman who, because of poverty, are actually choosing medical assistance in death after they can't get changes in their social conditions, in this case, housing. And this is not, unfortunately, an isolated case. There's actually been quite a series, to the point where the Canadian government has actually put a bit of a pause on further legislation around medical assistance in debt because of concerns that it's leading people who are living in poverty, who often have mental health concerns or substance use issues, to basically go down this route, which is concerning. We've seen this in things like life expectancy. Again, not surprising for probably many in this audience that we've seen a big drop, in this case, in the US, in life expectancy at birth. And not everybody has borne that loss the same. We're seeing, non-Hispanic males in particular, who are bearing the brunt of this. And it's patterned, again, by this kind of racial and systemic racism. So what we can see on what helps and what works is when you have countries that have more robust social supports and that have greater equity, things are better. And there's quite a lot of evidence to support this. And this is just one of many graphs, looking at things like family policy generosity and things like the percent of poverty, and then subsequently things like infant mortality rates and how they fit together. So I'll just end my part here, where we essentially have a hugely unequal society, both at an international level and at a national level, and within countries, even within cities like Chicago or Toronto. And we can predict what we're going to be seeing. And the challenge for a lot of us is, how do we take action on this? And this is, I think, where global health and our work and what drives a lot of us comes in. I'm going to turn it over to Ross to take on this next part, where he's going to go through some definitions and introduce kind of global health methods.
Thank you, Andrew, and thank you everyone for the opportunity to be here today, for the hospitality, for the interactions. It's been a truly spectacular day. I'm going to try to stay confined in my space here by the microphone and the camera. It's not my and if you see my glasses going on and off a lot, I'm in that indeterminate phase where I need glasses for distance, but I can't see things close up. So bear with my limitations, and I apologize for them. So the most, I think, cited and common definition of global health is this one from Copland in the Lancet. And just as a career tip, if you want to have influence, get something in the Lancet, and it will be by almost de facto the standard. So it talks about an area of study, research practice, priority on improving health and achieving equity for all people worldwide, transnational health issues, determinants and solutions, multidisciplinary, beyond health sciences, promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. Great, it's everything that we want to do. But what's missing from some of these definitions? So are we going to how is power distributed? Relationships, does this actually interdisciplinary, does this cultivate a relational base? We just had a really lovely discussion about Ubuntu and relationality. Systems that have been created and actually perpetuate and maintain these inequities that Andrew has so graphically demonstrated. And we could have spent several hours just looking at slide after slide after slide that would have reinforced the message. And an explicit discussion of ideology, of the framing beliefs and ideas that motivate our action. So compare the following. World Health Organization, we all know this definition, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Many people have thought this to be one of the most sort of fanciful and aspirational definitions possible. Versus the People's Health Movement. Health is a social, economic, and political issue, and above all, a fundamental human right. Inequality, poverty, exploitation, violence, and injustice are at the root of ill health and the deaths of poor and marginalized people. And we know that the World Health Organization accepts these because they had a major report on the social determinants of health, chaired under by Sir Michael Marmot, released in 2008. So we like to think a different approach. Like, we know that global health is a contested term. It's favored by academics and practitioners, and mostly it's a discourse in high-income countries. It describes activities that were previously labeled as tropical medicine or international health, and the stated goals, though they include reducing health inequities and improving the health of everyone, They reflect the roots in public health and human rights. Interventions span a wide range of activities and cut across disciplines. We agree there. But these interventions themselves are often shaped, formed, constituted by social, political, and economic philosophies of those who fund and direct. So there's a wide, an imbalance there. And it's relevant to discussions of health work with marginalized communities in high-income countries. So why should we be concerned with ethics? Why bother? I often ask myself that question every day as someone who's worked in teaching ethics for 30 years, chairing ethics communities. So it's like, why do I get up and do this? Well, there's a deep intuition. Those of you who are parents who may have read, the Madeline books, there was this, Miss Clabell would say, something's not right, something's quite wrong. We have an intuition that something is quite wrong with the world that we live in, locally and globally. And from that, we start to reflect on a deeper understanding of how power actually shapes this, about how access to resources, opportunities, the sort of currency of justice is inequitably distributed. And as a consequence of that, we have deeply unfair structures. And they have existed not just in the last year. It's not like if you hit your screen and press refresh, but they go back centuries. And we have to start to think about and interrogate each level and understand how these are all linked. And this brings us to the sort of twin dual purpose of what our action and our practice should be, which would be to avoid harm, where if we wanted to, I always get amused by people that said, I'm a Hippocratic physician. First, do no harm. Well, primum non nocere. Well, that's Latin, Socrates was Greek, and he actually never said that. He actually said help or at least do no harm. So we want to minimize the harms we do with good intentions. But how do we do that and effectively reduce inequities? What are the steps that we need to take? So I'm going to quote from an Indigenous scholar in Canada who's written this beautiful essay on the ethical space of engagement. And again, reflecting on the workshop on Ubuntu, I am because you are. It's interesting, if you Google Ubuntu, you get, it's a Linux operating system, which is kind of an interesting direction. But, I find this to be an astonishing piece of scholarship because if you read we've gone through a process in Canada with the Truth and Reconciliation Commission report, which is a damning report of how colonial activities actually affected a genocide of Indigenous peoples in Canada. And the fact that Indigenous scholars still want to create this space of engagement. So the opposite of Ubuntu is I exist because I'm going to extirpate you and take all of your space and all of your land and all of your places. So what we did in Canada was about as polar opposite to Ubuntu as you can get. And the fact that Indigenous scholar here is trying to say, I want to create an ethical space. What's in that ethical space? It's the space between us where we can actually open up a dialogue. And that's where I think, we could actually put a little Ubuntu into this ethical space to sort of start to recognize how we mutually recognize and understand each other. So he says the idea of an ethical space is produced by contrasting perspectives of the world. Recognize that there's difference, that you may not necessarily be in alignment until you actually try to understand each other. And it's produced by contrasting perspectives of the world, entertains the notion of a meeting place or initial thinking about a neutral zone between entities or cultures. And as we start to think about our work in global health, how much do we understand about the places that we think we're going to go and affect change and help out? And he says the space offers a venue to step out of our allegiances. And then you ask yourself, well, what are my allegiances? What am I allied to? What am I committed to? There's clear epistemic commitments because we believe in bioscience and that the bioscience and technology are going to improve health. But is that an allegiance that we necessarily have to be entirely wedded to? Because we might need to detach from the cages of, he calls it our mental worlds, and assume a position where human-to-human dialogue can occur. And I think this is a very powerful, and just the generosity of spirit to actually want to create a space to engage in this kind of dialogue after everything that's happened over the past 500 years since contact, I think is truly remarkable. So I also like some of what Paul Farmer has to write. He talks about structural violence. He talks about how about the structures of gender, ethnicity, sexuality. And so he says any distinguishing feature of a person or a population that creates a pretext for discrimination and a creation of suffering. Do we know what they are? Do we know how they're operative? Do we know how we in our practice and action are actually enacting, enabling, and advancing those features? And this was alluded to earlier, two American scholars, Larry Gostin and Madison Powers. They talk about public health, and we're taking a public health point of view here, but I think it actually fits in with clinical medicine as well. So an account of justice, and what's involved in this justice? It's the fair disbursement of common advantages and the sharing of common burdens, and the human well-being by improving health. And that's a very powerful tool that we have as health professionals, but to do so by focusing on the needs of the most disadvantaged. Now, does that commit us to a certain prioritarian worldview? Well, if we're interested in equity, then we're going to have to take this seriously and think about how all of those structures of power and resources play out and how we are working with them. Two other cultures, just quotations, I like quotations. Culture does not explain suffering. It may at worst furnish an alibi. And one of my colleagues from Global Health, Godfrey Tongwa, a Cameroonian philosopher, said, Western cultures have big mouths and little ears. So I've been trying to grow my ears over the past decades to try to be a better listener and, less of a pontificator. So ethics involves us to think, in my view. It's a critical inquiry. None of us chose the century we were born in or the place of birth. And by virtue of that, the culture that we inhabit, the ideas that frame and constitute who we are, we didn't have a choice in that. So we have to start from that, where's my colleague who did existential phenomenology and hermeneutics? Yeah, we have to start from situatedness and historicity. We have to understand the historical horizon that we have inherited in order to start understanding where we are. And to pick up from that lovely quotation in the workshop from Desmond Tutu, we have to reject a Cartesian point of departure, and we can somehow separate, we can step out and become atemporal and ahistorical and find a kind of, as Lee Irvin was saying, a God's eye view of the world. And reasoning is dialogue. We've already pointed out this. We have to be open. We have to risk ourselves and recognize that we may think we have the answers when in fact we may not. We may actually be a creator of problems rather than the solution. This notion, it was hard to learn during COVID, that revisability is actually a criterion of rationality. If the evidence changes, you have to change your thoughts. And we have to really think about how we justify our actions. The questions of justification are clear. And managing disagreement. If I have one pearl of wisdom to offer everyone from years of chairing ethics communities, do not assume agreement on values. I walk into every meeting presuming disagreement. It's just going to take me a while for people to surface what they actually think and believe. So we need to manage disagreement because disagreement is there, and there are, constructive ways of managing disagreement and very destructive ways of managing disagreement, as we all know, because of the, huge burden of violence that we see in our world today. So there's some ways of thinking about this. So there's reflective techniques. It's what I call fair explication. We're often, consumed with the view that we are correct, and I'm going to tell you why I'm right. But do I actually understand who you are and what your perspective is? Can I actually explicate your stance and do it in a way that's fair and that you would agree to say that, yes, that is where I stand from? How do we relevantly discern what the morally salient, ethically salient issues are? Because they don't come with labels on them. They're often very much enmeshed in empirical or other considerations. So we need to spend some time thinking on how we're going to discern these. Reversal tests are really an interesting mental trick, as you just take the opposite, the contradiction of the point of view that you're advancing and work through back. So I often take people through, okay, so you want to move forward in this. So is option A good? No, I don't like option A. Well, is the opposite of option A not A good? No, I don't like that either. Okay, so let's move in and from that and see how we can find a common space. Numbers and narratives means that, many of us are committed to quantitative rationality. But we need to really, I think, grasp the importance of narrative and the status of narrative as evidence. I won't go on this for a long time, but I've done some writing on how narrative actually does have constitutive and good standing as evidence as an RCT. And then back to this kind of polarization, or not polarization, I'll call them poles of a dialectic. So this is my training in, just a disclosure, I was a philosopher before I went into medicine, and hermeneutics. So there's two, hermeneutics is the theory of interpretation. The principle of charity holds that you take the argument that you're more or less against, and you put it in the best possible light. In other words, you fill in the gaps, all the enthymemes, all the suppressed premises, you make it the best case possible. And you hold that interpretation. So that's the charitable. And then what Paul Ricoeur calls the hermeneutics of suspicion, that underneath any statement that you or anyone else makes is a tacit ideological power distortion that you need to diagnose and expose. Now, my view is that you can't live in either of those poles. You have to be working between the two. You have to be charitable and suspicious simultaneously in order to get a grasp on the issues. And of course, ideology is important. And ideology, is classically defined, is the veiling of something that's socially constructed to be seen as part of natural necessity. That's kind of the classic Marxist definition of ideology. So primogeniture, that everything goes to the firstborn, that was because that was the order of the universe. Franchise for women, of course women couldn't vote because they don't have full rationality, but that was considered to be naturally the case. Slavery, from time immemorial, it was seen that some humans were of a higher and different order, and it was quite legitimate to have others completely at their service and be owned as objects. And so the question I ask is, to what big idea are we enthralled? We may not know at this time what the ideological shaping of our thinking may be. 20, 50, 100 years from now, they may be looking back at us and saying, they really believed that? I can't believe Upshur Pinto came to Chicago and gave all that. So I'm going to talk a little bit about, so there's a framework from colleagues of mine, Solly Benatar, Dalla, and Peter Singer, not the Princeton Peter Singer, the WHO Peter Singer. And this one comes from the early 2000s when global health first started to come into the forefront, where they articulated some principles that might want to animate a global health approach. So respect for all human life, and I think as we move into a planetary frame, actually another disclosure, I started in environmental activism before I went into medical school. And was very interested in environmental ethics. So this notion of the status of non-human organisms and what it means for us to coexist. So I would take out that human life and say, well, we might start to think about what sort of respect for all forms of life, including viruses. Attention to human rights, but with human rights come responsibilities. So with a right comes a responsibility, duties, and how we think and navigate how we address needs. Equity, which we've spoken about, freedom and democracy, solidarity, which we'll speak of a bit more, and moral imagination. How is it that we can reimagine a world that and move towards it looks very different from the world we have today? And I must say that some days I wake up, it's very tough to have moral imagination. And that's why I love coming and meeting students who seem to have that germ of moral imagination that rekindles a spark of optimism. So I'm going to hand back to Andrew.
So we thought it'd be useful just to make this concrete with an example. And I suspect this is something that many of you will have seen in your work or even have been, participating in. There's an organization in Canada called Me to We, which was really a very prominent, and it still is an organization. But this is a news article from 2012, when it really talked about the need to support others through these huge events, these We Day events that brought together politicians, rock stars, and others to kind of preach to a whole bunch of young people, students usually. But one of the things that really characterized them was this kind of idea of social enterprise and socially conscious and environmentally friendly products, and this as the way to creating solutions. And I'm sure many of you have seen this type of thing of purchase this, in this case, $300 bag, and it's going to lead to these types of changes that you're going to see. And, picking up on what Ross said about ideology, one of the characteristic ideologies is consumerism, is that the solution is going to be through the way that we consume things. Reinforcing the relationship too between the West and other countries in this type of way. And is your spirit indestructible? Be the first to own this tank top and build a school. Like, this is now, thankfully, has become kind of a cliche that we are more easy to recognize as, problematic. But it's something which, this is just 10 years ago, was completely bought into, and to such a level that our current Prime Minister, Justin Trudeau, was at these events and would be a huge supporter of this, and so it's now, in light of some things I'll mention, it's now, we can laugh about this and kind of say, like, but it's like Ross said, what are the ideologies that we buy into right now that then characterize the way we do global health? Here's another, and many of you will be well aware of the issue of volunteerism, but this type of thing of, have a great trip with your family and build a school on, the side, on a side trip, that type of thing. And this, not unexpectedly exploded, and it became a national scandal when it turns out that the Liberals, in this case, this is Justin Trudeau, our Prime Minister, with his wife, who were speakers at these events, were found to have given a contract to this charity to do a huge, like $900 million, to do student training and volunteer programming without any kind of oversight, without any kind of due diligence around why that contract was granted. It created, a big investigation into this charity, and it's led it to shut down a lot of its work. And it's, these things happen, but unfortunately, it took investigative journalists to unpack this. And I highly recommend this podcast called The White Saviors by Canada Land, which is a podcast and news kind of group. Because I think it gets into not just the details of this type of scandal and this organization, but it also is a mirror. It reflects back to us what we are doing, and where so many of our students come to, and so many of the families of those students come to when they think of this type of work, when they think of this. So global health ethics, is part of this, evaluating different courses of action, both at the individual level and at the collective level, and what the consequences are. We often, I think, focus a lot on this level of the individual. What am I going to do or not? And was it ethical? Should I have, done that surgery on that kid in that country, on that elective or not? And what did it lead to? It led to an injury, a permanent disability. There was no oversight. But there's also these things at the community level that we need to think about. And also, how does our collective action, we were, again, this morning talking about that. What's the cumulative impact of many students, many trainees going to a community over many years? And what does that say? How does that shape a community as well? And so global health ethics helps us to introduce a critical mechanism of analysis that considers power, resources, motivations, how this can lead to harm or benefit, and it unpacks scenarios to consider latent issues. It considers history and provokes us to consider them. One of the things that I think we often wonder about is what is different about global health ethics compared to just ethics in general. There is a lot that is different, the difference of the situation. Often they are more acute. There's often a higher burden of disease, a higher burden of illness. There's often fewer resources. There's often greater power differences that are reinforced by things like colonialism. There are almost always cultural differences. And there's also the greater importance of the social determinants of health and structural violence. So many of the things actually suggest we do need a different level of thinking, a different framework when we come into this. I'm going to turn it back to Ross to just go through 4 kind of value principles that we outlined as a start of a framework.
Thanks. So this is the had the good fortune of meeting Andrew. You were in medical school,
Yeah,
right? Yeah. So we started our relationship and friendship, and decided to write the paper that was alluded to. And it was remarkable because the publisher actually came to us and said, "Hey, you know that paper you wrote? Can you turn it into a book?" And we said, "Yeah, sure, why not?" So we edited this book. We brought together people that we knew that we thought could make a contribution, and edited this text, which in a shameless plug, we're doing a second edition. So in the paper, we proposed 4 ethical principles. And the first one is about humility. And that's hard learned in medicine, as I've experienced as a clinician, as a clinical teacher, because we would really like to train our physicians to have the opposite of humility, which is a rather overabundance of arrogance sometimes. We're the experts, we're in control, we're in charge, we know what we're talking about, we're the experts, let us do it. But we believe that not just in global health, but in day-to-day practice, humility as a virtue is an important consideration to recognize our own limits in terms of our clinical skills and experience, to challenge some of the practices that our institutions are actually promoting, such as medical tourism. To question, as I started at the beginning, where we are in the world, especially where it seems that some lives are more valued than others. The number of times I've been at Global Ethics, going to do a guidance document. Oh, what's the first principle? Each life has equal moral value. Oh, do our practices and systems actually really realize that? And to ask questions of whether through our practices are we actually reinforcing neocolonial strategies. And decolonizing one's brain is a very difficult undertaking, as I will attest to. And it's especially important in research, and we can maybe discuss that. Introspection. I said ethics is about thinking about thinking. What's motivating us? Why do we think it's in our interests to go somewhere else and do some clinical work or some research when there's unmet need in my own backyard? Is the expense justified? Are we coming from privilege, whether it be by virtue of our class membership, ethnicity, gender, or education? Have we actually engaged in an analysis of anti-discrimination? And what will be the impact on research? And how are we going to address the knowledge to action gap? Solidarity, I mentioned in the framework that Solly Benatar and others came up with. Solidarity is a very complex concept. There's some excellent scholarship on it. The Director General of the World Health Organization, if during COVID he said solidarity once, he said it 100 times. And we actually started to knock on the door as the chair of the ethics, the co-chair of that committee. What does the Director General mean by solidarity? But it's actually, there's a lot of ways of playing it out. So are your goals actually aligned with those of the patients and communities that you're working with? We've done the work to figure out whether there's a convergence there. How do you deal with conflicting visions of health needs? How do you bridge power imbalances? How do you deal with the multiple challenges, economic, political, and social? How do we work towards creating a global commons? And this notion of moral imagination, again, our ability to imagine ourselves in the shoes of others and to change our outlooks and actions on the basis of that understanding. And finally, social justice. Again, I'll direct you to the work of Madison Powers and Ruth Fadden, a brilliant book on social justice and public health. But our commitment to diminishing gross inequality and to address structural violence, to have an explicit commitment to social justice tied to equity and action, and to start to think about, and again, this comes from Paul Farmer, to try to find a way for us to encourage historically deep and geographically broad analysis of the places and spaces that we wish to travel to, and to examine power relationships and understand one's own role, and then how do we try to move towards a global perspective. A colleague of ours, Anna Manuel Byrne talks about social justice and political economy. It's need to consider the political, social, cultural, and economic context in which disease and illness arise and examine the ways in which societal structures interact with the particular conditions or factors that lead to good or ill health. I'm going to turn it back to Andrew.
So I'm going to just end the presentation with a few additional thoughts that kind of build on this. So many of you, will know Engels as famously as the co-author of the Communist Manifesto with Marx, but he wrote an incredible analysis called The Condition of the Working Class in England, well before kind of early thoughts about public health, before the Broad Street Pump and before many other reports that came out. And it was an incredible example of social epidemiology. And what kind of from this work, one of the really powerful ideas that came out was that health was determined by these social forces. And he famously called it social murder, that it was what he witnessed was workers who were being put into conditions which were just impossible to maintain health or to live long. So this is the type of analysis that we think of when we think about taking a political economy approach. And to bring this right to the present day, this is a quote from an NPR news item and podcast from 2021. And it's really, I'll give you a moment to read it, but it's about a nurse in the midst of the COVID pandemic in New Orleans. And you can just see, in her voice, and naming capitalism as the reason that, she breaks down, feeling overwhelmed. And when you understand, as she says, I understood what it means when people say you're a cog in a machine, feel obligated to show up to work. And that if she stopped working within a month, everything her family would have would be gone. And so what does it mean? Capitalism means I don't have a life, I don't get choices, and I don't get to decide. And this is the reality of so many millions of people in our own countries, not just the U.S. but Canada as well. And the importance of hearing these stories, but also bringing this into our analysis and into the work that then we do in global health. So one way to think about this, because it can be overwhelming to think about these big forces, and sometimes students, I think, who hear this say, well, at the end of the day, it's capitalism. There's nothing I can do. It's just all due to that, and good luck. But to try to break it down, starting to introduce to students and to all of us, taking a graduated approach. So thinking from that individual interaction, how does this shape their family, their community, the region, and how it functions nationally and then internationally? And that sometimes can help us a lot to make this more easy to process, and also to see what is our role, what is the piece of it that we're doing. How many people here are clinicians or did clinical practice in the past? So a good over half of people. So to try to make this tangible, and this is coming towards the end of our presentation, imagine you're working in a low-income country setting. You are doing clinical work and you have a 5-year-old girl who has pneumonia. The way that we train people is to make that diagnosis and to give the antibiotic. And it's being provided, in this case, in an NGO clinic that you are doing an elective in or doing a stint in as a resident or faculty. But think about all the pieces around that. Was there culturally appropriate care? And was there consent? Who consented? Did the family understand what you were doing? Was there a translation service? So many times we do work in these contexts, there's no translation. It's just, I'm doing this work, there's a huge amount of assumption. What about follow-up? How often do we see where someone gets treatment, they're just sent out and there's no follow-up? What if that little girl had an allergic reaction? What about thinking more upstream? What about a vaccine? What in that country, there's a recent report from the WHO about the lack of access to vaccines for pneumonia and how it's leading to hundreds of thousands of children dying prematurely for the cost of now very, very inexpensive vaccines that exist. What if she was also living with HIV, and did that how did she acquire that? How does this relate to a whole bunch of other factors that led her to develop pneumonia? Why are they going to an NGO clinic? Like, are there user fees? And does that relate to the health human resources in that country? You know, and so on. And you can start to see that this simple interaction of diagnosis, pneumonia, here's the antibiotics, you know, it's part of this much bigger picture that we can actually help our trainees and all of us to walk through and start to see this much bigger context, and then really start to think about the work. And I work as a clinician, and I will be in clinic on Friday. And I don't think it means you don't give the antibiotic. The kid has pneumonia, will still need that care. But it's taking this bigger picture and saying, what should we be doing? Not just me alone, because I alone can't fix all of this, but what collectively can we do? And this is where we could start to really envision robust educational experiences that actually factor in many of these other factors. And you can envision that all of us in our work and collectively could be doing things at multiple different levels as well. So one thing that we are now thinking about and proposing, building on this other framework that we did, is thinking about moving from individual to collective action. Thinking about these kind of 5 ideas. History, how did we get here? How did we, meaning that situation, transpire, and what are all those factors? Resources in terms of money and power, how are they distributed and why? What's the underpinning, and how can, through our work, how can we result in a more equitable distribution of money, power, and resources? Values, what should guide our actions, and who decides on those principles? It was really neat, the workshop that just happened before this around a set of values from a different culture, and how that can be, you know, we can learn from that. And then also resistance. What can be done to change the situation? What's our individual role and the collective role as well? You can imagine, as your institution has developed relationships with some communities over 10, 20 years, you know, it's a really powerful, long relationship you have. And there can be things that can be done collectively, but that then opens up the space. So it could be collective advocacy, it could be collective developing of policy solutions. It could be bringing in people from other disciplines to try to tackle this. So just to summarize and to finish so that we have some time for questions as well, I think truly understanding what we mean by global health is crucial. And it's a journey that we're all on. A global health ethical lens can be helpful. And if we think about the individual level, we have these principles that we've outlined, but there's also something about collective action and almost an ethics of our institutions that would be powerful here. And of course, we all need more. There's more work to be done to put this into process, you know, because your institution here, from what we learned, you know, this morning, is one of the leaders, and you guys are doing fantastic work here. There's many other institutions that would, you know, are working to catch up. So there is lots of great work, but there's more work that needs to be done as well. So we'll end there, and this is our contact info. And thank you again so much for the invitation to speak.
Andrew, thank you so much. I mean, very thoughtful and impressive. I want to pick up on the slide you had a little bit ago, which looked at health across many different levels, and really embracing, when we talk about global health, this notion of hierarchies, that it's fine to look at health at the individual level, but so much of what is shaping health is trickling down from these higher levels of the hierarchy, and that it can be very helpful to look at the ways in which we can look at malnutrition, infectious disease at these different levels to understand it from a more holistic perspective. Great, understand that, an important exercise for our students. Yet I think that the big challenge and much of the ethics that we're talking about are about coming together at a grassroots and a community. Do you have thoughts and suggestions on, to towards your comments on collective action. How we can address those processes higher up in the hierarchy that are so resistant to change, are so historically embedded, and are so much about power differentials.
Yeah, and this comes to that thought of sometimes I think students can mistakenly come away with this, the only thing they can do is overthrow capitalism. So that's not the message that we want. We want them to understand all this, but actually see a complex, picture like this and say there's actually a lot that can be done. Just to take one piece of this, the past history of NGOs in that community. What has that been? And that's an amazing student project, actually. Like, imagine if part of their time was working ideally with another student from that community and doing a report on what's been the history of NGOs. I think we've all been to communities where you go and they're like, you're the 10th NGO that's here. And we're just repeating the same kind of thing. So like just bringing that all together and understanding and making some recommendations, that could guide future work, that's something very tangible that can be done. There's a lot here that relates to work that can be done by undergraduate students, graduate students, people doing their master's or PhD, and from many different disciplines. There's, things here that relates from engineering to environmental health to, that's one of the really amazing things is because these are complex, challenging problems, we can draw on many different parts of the university. And so there's lots there, and it's not saying any one person or any one initiative is going to do everything, but that there's many different parts. And this morning we were talking about that idea of having a long-term relationship allows for these things. You can build that piece and those puzzles together, as long as it's done in this right way, and it's changing. The objective is not only to have student experiences, but actually create change as well. Thanks. Other questions or thoughts that came to mind?
In education, broadly at Northwestern, and it's our education still seems very individualistic, like preparing you and what you're going to achieve and your goals and you're going to be the leader. What could be to with our education to sort of cultivate an orientation that's more finding more towards that collective?
Yeah, it's a great question. And I think so much of our education in universities is very much focused on that individual. Some thoughts that come to mind, we were talking about more interactions and connections between trainees here with the trainees from that actually come here to Northwestern. And what would that look like? That exists in the residency, some of the residency programs already, which is great. But could that filter into other ways? And that actually saying what we're going to try and do is we're going to see education as a joint initiative. And it's about learning together, something that's really challenging, really complex. I think another way is actually saying that this type of thing is less about your individual learning objectives and more about something that's like a collective, something that requires a collective effort, which could be take an issue and actually have multiple perspectives on it. And then people have to synthesize that together. But it's interesting because it relates to what Ross mentioned about the way that we are trained in a lot of the health professions is very, very individualistic and very much like you are going to be the expert coming out of this. And this is a lot about changing, saying that the expert in this case is the community and you are the learner. And so you need to work with the community to understand this and to learn from it. But that's some ideas. Yeah. Other questions? If not, thank you again so much.
Thank you.
Thank you.